Good evening, everyone. So, as Shan says, I'm Liz Levy. I work in the Early Learning Childcare Directorate, and I have responsibility for the COVID safety guidance for ELC settings, childminding settings, and school-age childcare settings. I'm going to ask each of our panel members to introduce themselves, and then I'm going to explain just very briefly how we're going to spend the next hour. Now, I'm not sure if we've got Said on yet. I haven't seen Said yet. Said, if you're there. Nope, but I have seen Jason, so I'm going to ask Jason to introduce himself, although he perhaps doesn't need much by the way of introduction. Jason, do you want to say hello?
Hi Liz, thank you, and I'm sorry I don't need any introduction. I've been on the telly a little bit less in the last 10 days. There's been other news, so I hope you're grateful. So I'm Jason Leach. I'm the National Clinical Director of Scotland. I'm a dentist who then did a public health training and a surgical training. I'm also married to an educator, the son of an educator and the brother of an educator. So we cover most areas of education. I'm the only one who ended up in a healthcare job, but I have some credibility because I have to listen to a high school teacher complain at the dinner table most evenings. So that hopefully gets me some brownie points in this crowd.
Thank you, Jason. Okay, Diane, do you want to introduce yourself?
Hi everyone. I'm Diane Stockton. I'm a consultant in public health, and I lead in Public Health Scotland on all the work to do with education response and the COVID vaccine.
We're also hoping to be joined by Said, who's one of our senior medical officers, but I don't see or hear him on the call yet. If anyone sees him dropping in, just give me a nudge and I'll come back and ask him to introduce himself, and we'll just muddle through as best we can without him until he arrives. So the session, we're going to have this in 3 parts. We're going to start by focusing on vaccination, and then we're going to touch on the policy on close contacts, and then in the 3rd part we're going to take some questions on a mixture of topics that have been submitted in advance. What we've done is we've taken the topics, the questions that you've submitted, and in some cases we've amalgamated them just to cover off as many topics as possible. So you might not recognise the exact wording, but you'll recognise the gist of the question. Diane's going to start by giving you the latest picture of COVID cases and health impacts and show you some evidence on the impact of the vaccine so that you can see exactly how that's improving things. So we'll start there. Said, if he joins in time, will then provide some reassurance about the evidence on the safety of the vaccine, but perhaps Jason can do that if Said can't join. That should help anyone who hasn't yet decided whether to accept the offer or has concerns for other family members about being vaccinated. We know the childcare sector is predominantly female and relatively young, and we're hearing anecdotally from sector bodies that staff are hesitating. Some staff are hesitating because of concerns about the impact on fertility and pregnancy. So Jason's going to address that directly with us this evening. Jason and Said will then respond to some questions on vaccination that were submitted in advance. Then we'll move on from vaccination to provide a brief update on the policy on close contacts under 5. We know this has caused some concern among the sector, so I'm going to update you on a recent review of the policy, and Diane's going to set out the public health rationale for that policy, and again we'll address some questions on that topic, and then we'll move to the last section with a mixture of topics, a mixture of questions. You can drop, as Shan said, questions into the chat as we go along. I can't promise that we'll address them in the short time that we've got available, but we will take them away and undertake to come back within around a week with answers, so we'll get back to you with those answers, so please do use the chat bar. I'm going to hand over to Stephen, who's going to keep us moving through the agenda and give us a little prompt when it's our turn to speak or respond to a question.
Thanks, Liz. Hi, everyone. I'm Stephen Edgar. I'm another member of the COVID safety policy team within ELC Directorate at Scottish Government. So as Liz said, I'm going to hand over to Diane first of all, and Diane's going to give us the latest picture of COVID cases and health impacts, and she's going to show us some evidence on the impact of the vaccine. Thanks, Diane.
Thanks. I'm sorry, I think I put my slides up too quickly, but anyway, they're there now. So thank you, everybody. So I've just got a few slides to show on the latest position, if I can get them to work. Is that working, Stephen? Has that moved on? Great. So first of all, the latest position on the uptake of the vaccine. So at the moment, you can see here the uptake across different age groups. And you can see in the dark blue the uptake of first dose and the uptake of second dose. So what you can see is that for most people over 40, 91% have taken up the vaccine, and nearly all of those have had their second dose. The 30 to 39-year-olds, nearly 84% have taken up the vaccine, and 75% of those have had their second dose. And for 18 to 29-year-olds, almost 77% have taken up the vaccine, and 64% have had the second dose. So we've got very high uptake of the vaccine. We've obviously got lower uptake as we get to younger ages, but certainly in terms of the age groups where you're more likely to have severe consequences of COVID, the uptake is exceptionally high. The reason that obviously it's so important for the vaccine to uptake to be high is because we have very good data on how effective the vaccine is. And you might have seen tables like this that talk about vaccine effectiveness. And I'm not going to talk too much about this. I'm going to show you some real world data.
Now joining.
Real world data for Scotland. But what this data is showing us is that, you know, that 90 to 99% of deaths that would have been happening due to COVID without the vaccine are prevented by the vaccine, and 95 to 99% of hospitalizations are prevented, and that around 80% of symptomatic cases, 65 to 90% of symptomatic cases. So that's kind of the general kind of official data on this. But if we look at what's really happening in Scotland, then that really gives a really good picture. So this graph shows you deaths in Scotland. It shows you the 3 waves of the pandemic. It shows you early last year, and this is deaths by age, and it's the 80 pluses that you can see that really stand out in terms of deaths, and then to a lesser extent the 60 to 79-year-olds, and then the deaths are very low in ages below that. But you can see the first wave, the second wave, and then you can see the third wave, which we're in now, which has a far lower death rate due to COVID, and that's due to the vaccine. And what we know from our data, because we can look at who has died from COVID in the last week, in the last 4 weeks, and what we know is that just over the last week, or looking over the last month, that individuals are not vaccinated are 4 times more likely to have a death related to COVID-19 than those that are fully vaccinated. This is also true of hospital admissions. So this shows you hospital admissions over time, and again you can see the different waves of the pandemic. When you look at this graph, just remember how many more cases there are in this wave than there were in previous waves, but we're not seeing a corresponding spike in the hospitalizations. We've got less hospitalizations now than we've had in previous waves. And of people that are in hospital at the moment with a COVID diagnosis, they're 3 times more likely to be in hospital if they haven't been vaccinated than if they have been vaccinated. And this is not just true for older people, it's true at any age. So when we look at 18 to 29-year-olds, they're 3 times more likely to be in hospital if they're not vaccinated. The same for 30 to 49-year-olds, etc. 34% of hospital cases last week were in unvaccinated individuals, and individuals are most likely to be hospitalised when they're over 70. If we move on to cases, this graph shows just for the last month. This graph shows again back for the whole pandemic. I'm getting myself confused now. Back to May. It looks at vaccine status of people that are getting COVID, and what it shows is that the kind of lighter blue line shows that if you are vaccinated, your rates of COVID are much lower than if you're unvaccinated or if you've had 1 dose of the vaccine, which are the dark blue lines and the kind of purple line. And what we know from the scientific literature is that even if you do get COVID, then you're less likely to have severe COVID. And we know that because you're not as likely to be hospitalised, and because there are studies that have looked at symptoms of individuals that are vaccinated versus unvaccinated who've had COVID. The highest proportion of cases that's really driving those big spikes is the under 30-year-olds, and it's driven by people that are unvaccinated. If we look at what I think you're particularly interested in is the rates by age. So this is cases by age, and you can see at the very bottom the case rates for under 5s. So the case rates for under 5s are the light blue and the dark blue lines, which are very near the bottom, and they're as low as the 65 plus age groups, which you can see there. And we don't think that this is due to less testing in the under 5s, because the proportion of cases that are positive when a child under 5 does have a PCR test is below 5%. This is much lower than any of the other age groups. So that indicates to us that there's not a lot of undiagnosed infection in the age group. And there's also an infection survey called the ONS infection survey, and that estimates, that takes blood samples from age 2+ every week in Scotland, and that estimates infections are the lowest in the under 5s as well. So last week we had 385 cases of COVID in the under 5s in Scotland. The other thing that we're doing obviously is the Lfd testing, and a lot of early learning child care staff do take part in this.
Is now exiting.
Last week 6,755 ELC staff had reported an Lfd test, and of those 19 were positive when they first got a positive LFD and then went on to get a positive PCR test. So you can see the rate that translates into a rate of 0.28, which is low, which is good. That's what we hope to see there. Just for information, we have done studies looking at risk of severe COVID among teachers, and we're able to do that through a linkage study where we linked the register of teachers to COVID diagnoses and COVID hospitalisations and deaths. And what this shows is that the risk to teachers was lower than people that were similar to them in the general population. And when we say similar, it means they came from a similar area, they were a similar age, they were a similar gender, they had similar comorbidities. We're at the moment, you'll hopefully be aware that we are working with SSC to try and get a similar register for all early learning childcare staff so that we can undertake a similar study. So as long as that gets approval from yourselves, we will do a similar exercise to this to look at risks for ELC staff. Finally, just quickly, just wanted to also let you know about the sort of data that we look at in schools. So we look at how many schools have got cases at the moment, and this is quite a complicated table, but if you're just looking at the percentages for primary schools, last week 58% of primary schools had no cases at all, 15% had 1 case, 20% had 2 to 5 cases, and then around 5% had more than 6 cases within them. So that gives you an idea of the sort of information we have and the sort of spread of cases at the moment across Scotland, and that most schools, which obviously are quite big settings, have got relatively few cases. We also look at incidence in ELC settings. So what we did see was a fairly large increase in cases in the number of settings with cases when the sector reopened after summer holidays, but the average number of cases in each setting was had remained very stable. So the kind of median number of cases in a setting has been at 1 ever since mid-May, and that was even when we had much higher case rates once we went below level 0 at the beginning of August. At the moment, the reported cases in the under 5s and ELC settings are falling, and the levels of infection within the settings tend to broadly reflect the levels of community infection. So when cases are going up in communities, then the levels go up, etc. So that's all from me. That's a brief summary of the current situation. Thanks.
Thanks for that, Diane. So we're going to move over to Jason now, and he's going to give us some reassurance and evidence about the safety of the vaccines.
I'm going to try. I'm not sure I've got anything planned specifically. Oh, Syed has arrived.
Apology, I was in another urgent meeting. I just managed to get away from there. So feel free to. Okay.
You go first, Syed. I was going to bluff my way through with personality.
Apology for being late. I have another meeting, so I was running late. So I think as far as the safety of the vaccine is concerned, I think I just to reassure colleagues that for any medicinal product that are used in the UK, they need to go through very rigorous process before they are authorized to be used in the UK, and that's also true for vaccines. And MHRA, who stands for Medicines and Healthcare Product Regulatory Agency, does go through very, very rigorous process before any of the vaccines are used in this country. And one of the other things we do is that I'm aware that There are some concern that this vaccine was almost fast-tracked, and people thought that produced very, very quickly. However, I can reassure you that there was no corners were cut. It gone through every process, safety process that required to go through before MHRA gave the authorization. What is also more important is that once we actually introduce the vaccine, we continue to monitor the safety of the vaccine. In fact, as of end of last month, so far, we have used 42 million doses of the Pfizer vaccine, 49 million doses of the AstraZeneca vaccine, and 2.6 million doses of the Moderna vaccine. And what happened is that we actually encourage the member of the public as well as all healthcare professionals to report any adverse event, even if that adverse event not necessarily is due to, as a cause of the vaccine, but simply any adverse event that happened to happen following vaccination, we advise people to report. And there has been quite a lot of report, about 3 to 6 reports per every 1,000 doses since the program started. However, when MHRA looked at them very carefully and closely, vast majority of them are basically the adverse event that you expect. Basically, injection site reaction, fatigue, flu-like illness, and fever that was already picked up during the clinical trial. As you know, there are clinical trials before the vaccine are authorized involving anywhere between 20 to 40,000 people in each of the vaccine. Having said that, as I say, because of that, because there are often very rare side effects, which you don't pick up by doing clinical trial involving even up to 500,000 people, that's why we do post-marketing surveillance. Basically, we monitor what happened after the vaccine was introduced. And as I've just said, nearly 100 million doses of the vaccine used in the UK alone, and worldwide, literally billions of doses used so far. And what we do, the JCVI, the Joint Committee on Vaccination and Immunization, is the UK-wide scientific body, and the MHRA, they link up with all the other national and international bodies across the world. And they share data, the safety data, what is happening elsewhere. And based on that, we make decisions, and quite often we actually modify our program. And there are 2 examples. For example, there was, as you probably heard, the AstraZeneca vaccine, which very rarely caused blood clotting with low platelet count. Platelet is a cell that helps with the blood clot. And what they've done, JCVI and MHRA immediately adjusted the program because we found out that people who are most at risk are mainly under 40-year-old. And immediately they said, okay, we're not going to use AstraZeneca going forward in under 40-year-old. So as soon as you identify any signal whatsoever, those agencies and the bodies immediately actually advise the UK government to adjust the program accordingly. And that's what they've been doing. So I can reassure colleagues and those online that there is robust mechanism in place in this country to identify and respond quickly to any adverse event. And to date, MHRA and JCVI, certainly their view is that overall the safety of the vaccine is paramount to all of us, and the benefit of the vaccine significantly outweigh any small risk. And the other thing is we also picked up is called myocarditis and pericarditis, inflammation of the heart muscle and the heart lining. Again, very rare with the Moderna and the Pfizer vaccine, and mainly affecting younger people. And that's why initially JCVI suggested that we only give the first dose of the vaccine while you try to gather further information from this country as well as worldwide. So I just want to reassure, sort of the audience and others participating in the Blether is that we do not make this scientific bodies do not make this recommendation very lightly, because we know we are vaccinating millions and millions of people, and it's important that vaccine is as safe and probably the safest any medical intervention we can do. Over.
Thank you very much, Syed. So as Liz said a few minutes ago, we're now going to go to Jason, who's going to directly address some of those concerns that some of you may have about the impact of the vaccines on pregnancy and fertility.
Yeah, so that's a relatively straightforward answer, Stephen, and Syed has covered the broad safety of the vaccine globally very, very thoroughly. It's really important to get your information from trusted sources. It is easy to find an alternative version to Syed's world, but it's a weird world to go into. It's principally on social media, but it's also sometimes in your WhatsApp group with people I don't know who have heard from cousin Johnny or Frank up the road or somebody in the pub. But eventually those stories lead back to social media, and they are deliberate and designed attempts to undermine the vaccination programs in the world. Most of them actually emanate from Eastern Europe. There's a huge anti-vax community in some countries of the world, and they erode trust both in their own countries, but because of the nature of global communication, they also begin to erode trust here. So you should get your information from trusted sources. You don't have to get them from the government, guy. You can go to the National Health Service, NHS Inform. You can go read the evidence that the Joint Committee on Vaccination have looked at. You could go, if you want to, you can go higher. You can go to the European version of that. There are hosts of trusted information. If you've got young people, then you might want to direct them towards Young Scott, who have a health panel who have helped us a great deal with some of this communication. So to deal with your specific question, and it does come up every so often about fertility, which is a different question from pregnancy. We'll come to pregnancy in a moment. Let's deal with fertility first because it's easy. There is no biologically plausible mechanism for the vaccine to affect fertility in any way. None at all. There is zero evidence. None. Not only no evidence, but we cannot even think of a way in which it would be possible for the vaccine to affect fertility. So you should discount it. And anybody who tells you otherwise is not telling the truth. Pregnancy is always a challenge when you introduce new interventions, because funnily enough, when you do the initial trials, you don't do those trials in pregnant women. You do those trials in healthy, non-pregnant men and women. Then you move into other categories, people with transplants, people with immunocompromised positions, and pregnancy. We've now given the vaccine to millions of pregnant women globally, and the risk is the same as for the rest of us. It is tiny. There is no additional risk to the fetus, no additional risk to the pregnant woman, and COVID is a huge risk for pregnancy and a huge risk to unborn children. So, like all things, the fundamental summary is it's better than COVID. It's significantly better than COVID.
Thanks, Jason. So we're now going to go to some of the questions that you've asked us in advance. So the first of those questions I'm going to pose to Syed, and it's how effective is vaccination for children, as we're only now giving them one dose and many children have already had COVID?
Okay, so I think the important thing is that just to, is that we giving the first dose, and we are waiting for further evidence coming both from this country and elsewhere internationally to see whether it's safer than safe to give the second dose. So we may still give a second dose. You haven't decided yet. So we're just giving first dose. We're not just giving one dose. You're right. There are obviously now that vast majority of the adult population have got 2 doses and they're protected. And what happened is that the shift of age of infection has moved towards the younger age group. And there are no doubt that more and more younger people are getting infected. And we also know that from natural infection, we can get good level of immunity. But certainly what we don't know is that how long does that immunity last? So I think what we are doing now is that to make sure that although some people may be infected, it is difficult to know because some people may be asymptomatic infections, difficult to know who have been infected, who haven't been infected. We are giving the vaccine to make sure that even if they're infected, the vaccine will give them the boost to the immunity they already achieved from the natural infection. So almost as a kind of safety net plus giving them a boost. And one thing we also know that once you've been vaccinated or you've been infected naturally, after some period of time, 4 to 5 months to 6 months, the immunity level gradually drops. Because the antibody that we produce as part of the immune response is literally protein. And with time, they decay. And that's what's happening with that. And that's why, as you probably heard, that in the UK and other part of the world, they have now recommended booster program for some adult population to give them the boost. So that's another reason why it is important to vaccinate children, even if they've been infected, because by giving the vaccine, we are giving them a boost to their immunity, and hopefully that will give them longer-term protection. And also, they're not going to act as a source of infection to their family members, because they may have family members who are elderly and at risk. So although younger people on the whole get mild to moderate infection, by protecting them, not only are giving them direct protection to them, but also indirect protection to them and their families. Over.
Thanks very much. I'm going to come back to another question for Jason now. So it seems as though decisions about the easing of risk mitigations are being made on the assumption that all staff are double vaccinated. That's not the case. Is that a risk?
There is no risk-free path. I've said in this forum previously, and the multiple versions of this forum we've had with different groups, that unfortunately, if there were a folder you could take from the wall and hand to the Education Minister or the First Minister, then you wouldn't need all the advisors she has, and you wouldn't need the complexity of decision making. There is no risk-free path. You can see even in New Zealand this week, held up as the poster country for the rest of us, taking a completely different approach this week compared to where they've been in the past, and now they're going to take more risk. So you're right. As we move into, let's call it a vaccinated world, the choices become different. The formula of harm versus cases changes dramatically. It doesn't change for everybody. It doesn't change the risk for each individual, but it changes the population level risk very dramatically. The best thing you can do is be vaccinated by a country mile. It's the safest and easiest way to protect you from the disease. It's not a foolproof, bulletproof shield, but it makes it much less likely that you will have a serious version of the disease and that you will cause others to have a serious version of the disease. But it is not risk-free. We then have to give advice and make choices about what we should do across the whole population. And that is how we've done the whole 18 months. So when schools were closed, that was an appropriate response to the level of virus pre-vaccination, with no idea of who the vaccine was killing or harming in the early days. And then gradually, you've seen us move away from that. So in a sense, yes, the decisions are now being made in a vaccinated world, and therefore the risk equation has adjusted. Now, how you react to that as an individual early learning centre or as an individual family or individual, those risks are up to you. And they have also been adjusted, because you're now allowed to go to the pub, you're allowed to go to the cinema, you're allowed to go to the theatre. So everything has changed with the way we do that, but you have to make individual choices while we're making population level choices.
Thanks, Jason. So for our final question on vaccination, we'll go back to Syed. So how much risk is there from non-vaccinated people or those who refuse to be vaccinated?
Yeah, as I think to a certain extent is a difficult one to answer, mainly because, as Jason said, to a certain extent depends on the amount of virus circulating in the community. However, having said that, this is extremely infectious virus. It can spread very, very easily among the community. Therefore, anyone who is not vaccinated, if the virus is spreading in the community, almost certainly going to catch it sooner rather than later. Therefore, if the person unvaccinated person actually come into contact with the case, they will get infected. And to a certain extent, they're almost playing Russian roulette with their lives, as well as the lives of their loved ones who they may come into contact with. Remember, some of the people who are most vulnerable, the very old, those who are with other medical conditions, they will respond to the vaccine, and most of them have been vaccinated, but unfortunately, they are more likely that their immunity will gradually drop because of their medical condition and their age, the immunity drop quicker than others. Therefore, anyone who are not vaccinated who will get infected, and then they will pass on their infection to those who are most vulnerable. And I think that's the issue. I can't tell you exactly what the risk is. It all depends on how common the virus is in the community and how likely they will get infected. But if they do, if the virus is in the community, you can guarantee that they will get, sooner rather than later, they will get infected and they'll pass on the infection to others. So I would not be very comfortable coming into contact with someone if I knew they're unvaccinated. Over.
Thanks, Lord. So that brings us to the end of the first section of the Blether on vaccination. See, there's been a bit of activity in the chat pane, which Jason has really helpfully responded to, so that's great. So we're going to move on to the second section, which is about recent changes to the close contact policy for under 5s. And first of all, Liz is going to give us a brief update on that policy on close contacts for under 5s.
So since Scotland moved beyond level 0 back on the 9th of August, you'll know that close contacts aged under 5 can continue to attend childcare settings without being required to return a negative PCR test. And that's provided, and it's really important, provided they show no symptoms. So the guidance on NHS Inform states that children under 5 who are close contacts are encouraged but not required to take a PCR test. We've been made aware through direct contact with the sector at the last Public Health Blether and through our regular engagement with sector representatives that this policy is causing some concern for childcare staff. There's a particular concern when the child's contact is a positive case within their own household, so with parents or other siblings. So in response to those concerns, we asked the advisory subgroup on education and children's issues to review the policy through what we call a 4 harms lens when it met on the 21st of September. Within the context of childcare settings, our 4 harms approach looks at 4 risks. One is the direct health harm associated with COVID. Next is the pressure on the sector, and that includes staff confidence. We know how important that is. Thirdly, the ability to deliver support for children's learning and development. And lastly, the financial harms, and that includes the impact on business sustainability for settings within the public, within the private sector. And also the ability to provide childcare that supports parents to work, train and study. So these are the kind of risks that we asked the subgroup to weigh up. And that 4 harms assessment was developed in close collaboration with sector representatives who sit on our COVID reference group. And it was also developed with input from Public Health Scotland. So the subgroup's conclusion at the meeting when they looked at that 4 harms assessment and looked at the evidence on the state of the pandemic and transmission was that the policy does continue to strike the right balance. Given what we know about transmission risk from very young children, the impact of excluding them from childcare settings, and the distressing impact of repeated testing on this very young age group. Now, Diane helped us to set out the evidence on the harm 1, the health harms associated with transmission, and she's agreed to summarise that for us here. So I'll pass over to Diane.
Thanks, Liz. Thank you. So, so as Liz said, I mean, the key areas of evidence are around case rates in under 5. So we know that the case rates in the under 5s have remained very low. There aren't a lot of studies that have looked at transmission under 5s, and this is largely because the numbers are so low that it's not been an area of concern actually in the scientific in scientific areas to look at that group, although as you know we're doing a piece of work to look at that now with yourselves to make sure that is the case. We also know that children to children transmission is lower than adult to adult transmission, so adults are more likely to pass to adults, and that of children, though younger children are less likely to pass to other children. We also know that when you're asymptomatic, you're less likely to pass COVID on. So again, as Liz said, the symptom vigilance is like really key here. That no child who's got kind of the cardinal symptoms should be attending. That would be a completely different situation. And then the other key area for the evidence was around the vaccine and the fact that all vulnerable adults have now had the opportunity to have 2 doses of the vaccine. Not everyone has yet had 2 doses, but those that haven't are lower risk individuals who are less likely to have severe outcomes from the vaccine, and the effectiveness is very high of the vaccine almost everyone. And that doesn't mean that no one will get ill, as Jason said, but what it does mean is that we're in a very different situation to before. And then the final part of the evidence is around children's risk of severe COVID, and again, children tend to have very low risk of severe COVID harm, and so that was the other factor that played into that decision making. I think that's probably the key evidence, Liz.
So I think an important point to make is that, as always, the subgroup will keep a close eye on the evidence, and if it suggests that the policy needs to change, it will update its advice. It's worth highlighting again that data linkage study that Diane mentioned earlier on. That will be a really key piece in the jigsaw, help us to understand. We already have that data for teachers who want to have the same data, and it's proved really helpful in reassuring teachers about their relative risk. So SSC will be giving staff the option of opting their data out of the study over the next few weeks, so SSC should be in touch. We would encourage you not to opt out and to allow your data to be used in this way. It's really helpful and really crucial to help us make sure that our risk mitigations are proportionate. So a wee plug there for the study.
Yeah, just to reassure Liz that although we need individual name data in order to identify who within our whole set of people that have had COVID are working in the workforce, we don't then, as soon as we've put kind of a little flag on our health data, we don't then identify individuals at all. So it's only to enable us to identify initially who is, and then we don't use any kind of personal data at all after that. So
Thanks, Diane, for that. So we do have a couple of questions that you've asked us in advance about the close contact policy. So for the first one of those questions, we'll go back to Jason. So do staff need a PCR test if a child under 5 tests positive? There doesn't seem to be a consistency about whether staff providing childcare should be defined as close contacts.
So Liz will keep me right here because it changes a lot, and Liz has to actually write it often. Around other people's advice. So my understanding is there isn't a simple yes/no answer. It's a risk-based decision. The answer is usually no. Standard contacts do not require a PCR for a positive under 5, but there are occasions when where a PCR would be required. And that would be in consultation with the Test and Protect teams, unless you had been in the scenario exactly before and you were in a particular environment where you knew maybe you'd stayed overnight. Maybe you were in very close contact with somebody with additional support needs, a kid with additional support needs, and it was hours long rather than a few minutes of normal contact of nappy changing or normal play. So it's risk-based, again, and it's not binary. If Twitter ran COVID, everything would be yes, no, wouldn't it? It'd be very straightforward. Unfortunately, the first tweet would be yes, no one way, and the second tweet would be yes, no the other way, because they yell at us whatever we do. Unfortunately, the real world, as you guys know, living in it and working in it, it's not quite as straightforward as that. So the fundamental rule is no, but if you're in a high risk, long contact setting, then yes. I think that's about right, Liz, is it?
Yeah, and Test and Protect will get in touch with you. And if you have any concerns that you might be in that kind of high risk, then discuss with your manager, and you can contact your health protection team and discuss the scenario. But the general rule is that that Test and Protect would contact you. So when a child tests positive, there's a conversation with that child's parent about where they've been and what kind of contact they've had. So that should prompt a wee bit more analysis. But the kind of day-to-day, business as usual contact that you have on the cuddles and the play wouldn't be regarded as high risk for all the reasons that Diane set out in terms of the risk of transmission from very young children. But there will be anomalies. I'm sure there will be because, in some cases it's a judgment that Test and Protect are going to make.
Thanks, Liz. We'll come back to you for the final question we've been asked in advance on the close contact policy. So staff are feeling anxious when parents send their children to childcare settings, even when they're displaying COVID-like symptoms. So what can we do to ensure that parents don't do this?
So Parent Club is really strong on this. It emphasises that it's extremely important that parents continue to look out for symptoms of the virus. And it makes it clear if a child has symptoms, they shouldn't be attending childcare settings. Parents should book a test straight away. And that message is also included in the warn and inform letter that's issued when there's a case in the setting. In terms of what we could do, we're always thinking about what more we can do to promote compliance, and we're open to suggestions here. We wondered, would it be helpful, for example, if we developed a poster that settings could display near the entrance to remind parents of that requirement? If you think that's helpful, drop something into the chat and we'll happily take that forward and develop something that will be part of the supporting documents for the guidance. Or if you've got any other suggestions too, let us know.
Thanks, Liz. Just before we leave close contacts, I think I'm just trying to keep an eye on the chat as well, but I think, Jason, you've been picking up on a few questions that we've been asked, so just to flag that there's some interaction going on in the chat pane as well. We'll try and pick up all of those questions after Blether if we don't get to them today. But we wanted to move on just to pick up on some questions we've been asked in advance in the third and final part of the Blether, just about the ELC guidance and a range of other topics. So we will aim to finish promptly, relatively promptly at about 7, but we will make sure we send around that summary of any questions that we don't get to pick up tonight. So for the next question, I'm going to go back to Syed first and then go to Jason. So it's a wee bit of a complicated question. So we've been asked by somebody who's heard about 3 cardinal symptoms of COVID, and that as well as those, other cold-like symptoms such as a runny nose and a sore throat could be symptoms of COVID in young children. So is this true, first of all? And if so, should children self-isolate and take a PCR test if they show these symptoms? And also on this issue, we've been asked, we've been told that some health boards have different lists of extended symptoms. So will the NHS Inform website be updated to include these?
Yeah, I think first of all, as you know, during winter months, even before COVID pandemic hit us, winter months children get all kind of respiratory viruses causing cold and flus. So I think we need to keep the risk into perspective. Thing about COVID, as you already know by now, that it provides a variety of symptoms from mild to very severe illness leading to ITU admission and death. And younger children, Diane already picked up, covered some of those. Young children on the whole get mild to moderate infection. Therefore, you can get a whole range of symptoms, including just cold-like symptoms. So it would not be unusual. However, we can't simply exclude children from, we need to keep the risk into perspective. We can't simply exclude children every time they get a bit of a sniffle or a cold, given that we have other measures already in place. For example, we got all adults are fully vaccinated now, those who are likely to be at risk from them. And also, as Diane said, the risk of transmission from children to children is lower than from adult to adult. So I think we need to just, given the benefit of sort of education and remaining in school, we can't simply every time someone had a bit of a cold and sniffle just say that it must be COVID. But clearly, if they got significant symptoms, it is important for them to make sure that they get the test and isolate themselves. And of course, people on the whole need to also continue to practice good, what you call the hand and respiratory hygiene. Respiratory hygiene being is that if they do have cough and cold, it's important that they use their tissues and bin the tissue and wash their hands to stop spread their viruses. It could be simply just one of the virus causing common cold. So I think given the current situation where we are, I think it will be a bit overreaction that every time someone got a bit of common cold or a bit of a sniffle, just exclude them for 10 days and send them for a test. We need to use our common sense and put the risk into perspective. Over.
So the reality here is there are 19 different symptoms of COVID. You can find them online. They vary from diarrhea to tiredness and we've done scientific studies on how to find the most COVID using the testing regimes that we have. So if we added all 19 symptoms every day, we would basically have the whole country going for PCR tests every day. particularly all the children. So I've had the cold for 10 days. I blame Mrs. Leach and the schools of Scotland for bringing it in, even though we hadn't had any in this house for 18 months. So I have not been for a PCR test. I have none of the cardinal symptoms, but I have continued to do lateral flow tests because I have symptoms, but not the 3 cardinal COVID symptoms. I could well have had COVID. I don't have COVID, according to my lateral flow tests, and I've done them repeatedly. But if you take the 19 and you do 15, you then think, okay, how far does that? So we've done massive trials across the whole world to say which symptoms should we get PCR testing for, bearing in mind we're doing lateral flow testing, we're doing other hand hygiene, we're doing vaccine, we're doing all these other things. And the scientific advice is the best bang for the buck, not the money buck, we could pay more. The best bang for the interventions we've got is stick to those 3 cardinal symptoms for PCR testing.
Thanks, Jason. So for the next question, we're going to go back to Liz. So when will it be recognised that the maintaining of 2 metre social distancing between staff in busy ELC settings is impossible?
Well, I've got some good news. When we moved down to level 0 on the 19th of July, the physical distancing requirement in indoor public places, as you'll know, it reduced from 2 metres to 1 metre. And at that time, or shortly after that, the advisory subgroup on education and children's issues provided advice about whether it was appropriate to make this change in childcare settings as well. The group's advice at the time was that when Scotland moved beyond level 0 on the 9th of August, the physical distancing requirements for adults in childcare settings could be reduced to at least 1 metre. But it said, the advisory group said, if the setting already has 2 metres in place and that's working well and doesn't impact on capacity, then they could retain that. So settings currently do and have had since the 9th of August that flexibility to decide for themselves whether to operate at 1 or 2 metres depending on the practicalities and their impact on capacity. Now, I know it's really difficult to stay on top of the frequent changes to the guidance that we make. We're constantly updating the guidance. So we've produced a checklist. I think there's a link in the guidance that summarises what the key measures are. So I'll drop a link into the chat. For those of you that are struggling to stay on top of the changes, that'd be a useful resource. It does need to be updated for another change that I might have time to come on to in terms of visits by parents. So maybe give us another few days to update it, but I'll put that checklist into the chat. I think it's a really useful resource.
Thanks, Liz. So for our next question, we'll come back to you, and then I'm not sure Diane might have something to add as well. So are we confident that the mitigations in childcare settings are sufficient, given what we know about the virus and how it's transmitted?
So I'll start us off, Diane. So I've mentioned a few times the advisory subgroup on education and children's issues. That's the group that regularly reviews our mitigations in childcare settings and also the schools and higher further education. That group is now chaired by Professor Linda Bald. She's the interim Chief Social Policy Advisor to the Scottish Government. She's also the Chair of Public Health at the University of Edinburgh. You might have seen her on the telly. She's almost on the telly as much as Jason is, so I'm sure you'll recognise her. Other members of the subgroup include other scientific and public health experts, clinicians and academics, as well as experts in education, childcare and children's services. And every time that group meets, which is every fortnight at the moment, it starts with a thorough review of the data and the new evidence on transmission of the type that Diane talked you through at the beginning of this session. And there's a specific focus on what the data is showing for children and for education settings. We also in Childcare Directorate review the data for childcare settings weekly. Stephen leads on that and puts together a really thorough slide pack that we send to ministers, and that's an opportunity for us to highlight anything that's given us cause for concern and suggest that we need to strengthen our mitigations. And we meet with Public Health Scotland once a fortnight and with others across government, including the Care Inspectorate, to see if we're all comfortable with what that data showing. So we keep that under constant review. The data has continued to show that childcare settings are low-risk environments when mitigations are in place. And Diane mentioned that data to you. What we see is that levels of transmission broadly reflects levels of community transmission. And even when we've seen more cases and more settings reporting cases, the average number of cases has remained around 1 in each setting since mid-May. And that suggests that there's very little transmission happening within settings, and that as a sector, it means that you're doing a great job of managing risks using the current guidance. So that tells us that actually we've got things about right.
Thanks, Liz. I'll just add, not much to add to that, but I'll just add that in Public Health Scotland, we look at the international literature to see and speak to agencies across Europe to see what they're doing, see what they're finding, and we also we meet weekly, well, every day pretty much, with the local directors of public health and the health protection teams, and we get intelligence from them on anything that's emerging. So that all gets fed into this experts advisory group that Liz has mentioned, where we consider everything and reach decisions on what we think the evidence is saying. And at the moment, we feel content with where things are.
Thanks, Diane. We're rapidly running out of time, but hopefully just have time to pick up a couple more questions. So the next one is for Liz again. So it's about enhanced cleaning of resources after each session, or isolating resources for 72 hours. And we've been told this is having an impact on the kinds of resources that can be used, and there are concerns that it could impact on the delivery of 1140 hours. So are there any plans to revisit this requirement now that there's evidence that childcare settings are fairly low risk?
Okay, so again, I've got some good news for you. The guidance explains that there's no longer a requirement to quarantine items for 72 hours. What it says is that enhanced hand hygiene is now a more proportionate way of reducing the risk of fomite transmission from surfaces when resources, things like story bags, for example, are shared between settings and homes. So when a story bag comes back from a child's home, you don't need to quarantine for 72 hours. Just observe that good hand hygiene. The cleaning of play equipment between sessions has been flagged as a risk to delivering flexible childcare. We are aware of that. And we know that the challenge of cleaning between sessions means that some settings have decided not to offer half-day sessions that involve a change of children during the day. So we asked the infection prevention and control experts in Public Health Scotland earlier this summer to review that advice and to see whether it was still necessary or whether we could ease that off. At that time, they asked us to hold on to the guidance. Given the progress of the vaccination programme and the data that Diane has shared with you and the recent drop in cases, now might be a good time to ask them to reconsider this. I'd be happy to hear again in the chat bar about the impact this is having on service delivery, because we can reflect that in the 4 harms assessment that I described. And I'm very happy to take that question back to the infection prevention and control experts and see if we can ease that off.
Thank you, Liz. And I think we've just got time for one more question, which I think, Diane, you've raised in the chat bar, but I think it's useful to pick it up and focus on this question we've been asked. So it's from someone who is asking, how can they persuade their staff to keep taking part in the asymptomatic testing programme, and that they've heard that LFD tests aren't reliable?
Thanks, Stephen. Well, the LFD testing programme is complicated because it's more effective when there's a lot of COVID around, and it's less effective when there's not a lot of COVID around. So at the moment, it is an effective tool, and in outbreak settings, it's a really effective tool because people have a greater chance, in an outbreak setting to have COVID. So at the moment, if you do an LFD test, given what the current levels of COVID are in Scotland, if you do an LFD test and it's positive, then you've almost definitely got COVID. You're 95% the likelihood that you've got COVID. So when you go and get your PCR test, it probably will be positive as well. That becomes less as the prevalence reduces of COVID more generally in the population, and it does. And with the current levels as well, it will pick up. So it won't pick up all cases of COVID, but it'll pick up about 2/3. So if you test 100 people, and then it should pick up 2/3 of those. So it really is an effective tool at the moment. So whether we can put, Liz, maybe we could put, you're talking about posters, maybe we could put something with some of these stats in as well to encourage testing, but we always have to caveat it with the fact that it's a good tool at the moment because prevalence levels are higher in Scotland, and it becomes less useful if they become very low. We need different methods. So I hope.
Diane,
sorry.
just going into
I went
mute.
off mute. I just said I don't know if anyone else wants to add anything like Jason on that point.
No, I think that's good, Diane.
Thanks, Diane. That's really helpful. So we are just about out of time. We certainly covered a lot of ground tonight. So I'd like to thank our expert panel very much for giving up their time. We hope for you that it's been helpful and informative and reassuring. Thanks to everyone who asked a question in advance or in the chat. Jason, you've been great at picking up some answers to those questions, but we will review the chat pane and make sure that we have picked up everything that we've been asked. And as we said, we'll send round a written Q&A, picking up all of the questions and providing answers to those. So thanks to all of you for giving up your time. It's been another fully subscribed Public Health Blether for childcare staff. Please complete the evaluation for the Blether. I'm just going to pop the link into the chat, and we'll also send it back out to you with the questions as well. Hope everyone has a relaxed evening, and take care. Thanks for coming.